So Alan, tell us about DEFINE PCI.
So DEFINE PCI was a study that evaluated patients coming in with stable or unstable angina. The total number was 500. It's a multi-center study. We had 27 centers in the US and in Europe. And what the goal of the study was to assess what is the percentage of patients with significant residual ischemia. So initially the baseline was to do an IFR. This was a spot IFR in the distal vessel. And maybe I can just point out that the concept of physiology so far has been to just look at what we call vessel-based ischemia, where we do one spot measurement, usually in the distal vessel, to see is there ischemia or not. And then the rest of the procedure is guided by the angiogram because we feel we can identify where the lesion is based on the angiogram and make a decision where to do PCI. So this is the fundamental concept that we challenged with DEFINE PCI. So we did one baseline IFR in the distal vessel. It had to be abnormal to qualify to enroll in the study. But then everything else was guided by the angiogram. So that was the concept. And so that included, by the way, intravascular imaging, which was optional to the operators. After the operators said, everything looks great, we have a successful result, there was a blinded IFR and, importantly, an IFR pullback. And what that is, we can discuss in a minute. Again, blinded, not known to the operator. And then the procedure was basically completed and the patients will be followed up, which is currently ongoing up to 1 year. Now, this is the distribution of pre-PCI and post-PCI IFR values. As you see, obviously the pre-PCI is skewed towards the left because the entry was to have an abnormal IFR, some of which are down to 0.1 or 0.2, very, very ischemic IFRs. And then you can see in yellow the distribution of post-PCI IFRs, which is a more uniform distribution, around 0.93 or so, but certainly also indicating that there is patients with significant residual ischemia defined as 0.89 or less.
And it's pretty safe to say that the operators in general think they've put their stents in, they've treated all the significant lesions that there are to treat. They probably would be pretty surprised by this result, but this was blinded. They couldn't see the post-PCI IFR.
And in fact, the entry was to have a successful angiographic procedure. There were some patients who didn't, who were excluded.
Okay.
So these are only successful angiographic procedures.
Okay. So yeah, in the clinician's mind, they thought they'd completed the job, done the right job, done the best they could.
Right.
All right.
And so this is the primary study endpoint, which indicates that of the 467 patients that qualified after core lab review, et cetera, 24% of those patients still had critical ischemia with an IFR of 0.89 or less. And then importantly, when we did the pullback, we were able to identify, is this just all diffuse disease that is difficult to address, or are there focal lesions that were missed? And it turns out that the vast majority of patients, and I think this is really the critical message of the study, 82% had focal lesions that potentially could be addressed with additional PCI.
So tell us, one of the beauties of IFR is the ability to do pullback and be able to very accurately distinguish between focal disease and diffuse disease. So how do you do that in practice, and what was your definition of focal versus diffuse disease?
So it's actually relatively simple. The way it works is that this is actually a manual pullback of the wire itself under fluoroscopic guidance. And when one does that, you can actually see the step-ups that you correlate to the angiogram, and there's also a way to co-register to the angiogram actually directly, and then determine are there focal step-ups or is it just kind of all diffuse disease. And that's important to do at rest, by the way, because when this is done with FFR, there is so much crosstalk between the lesions through the hyperemia that it's very difficult to assess each individual lesion separately. Under rest condition, that's possible, which is why IFR in this case is very good.
And you'll show us some examples, which
Greg,
we'll go through examples.
Make it one point, kudos to the design of the study, because we've been talking about this post-stent FFR business for a long time. But this study, one of the unique aspects was that when the pullback was performed, Alan and Manesh and the other leaders of the study insisted that the operators document exactly where the stent edge was during the pullback, both the proximal and the distal, and that's why you're able to go back and give such, accurate results as to where the problem is and whether it was focal, is that the pullback was done extremely meticulously with angiographic
Exactly.
And I think Alan might speak to us with that guidance of where the stent was. Tell us again, how did we define what focal was? Because I think that was another question people had.
So the way we did this was we looked at the step-ups. We arbitrarily set a step-up of 3 units, 3 IFR units we count as significant. And if it was confined to a 15 millimeter or less segment, it was focal. It was more than 15 millimeters, we defined as diffuse.
So the idea being that if you took a 15 millimeter stent or so, you would get that pressure change, so that if you were trying to act upon it, you'd have a very sort of reasonable stent that you would add to it.
Exactly. And I think when we see some case examples, it'll become even more clear.
And then one other point here, which is not in the slide, but I think important to make, of those 82% of patients with focal lesions, the question is, okay, what's the breakdown?
Yeah.
It turns out it's about a third, a third, a third. A third is there's a stent problem, a third is a missed lesion proximally, and about a third is a missed lesion distally.
Again, getting to imaging in general, but also helping you identify physiologically where it might be.
Okay. Now, the other important finding was that we also had QCA done on all of those patients in the core lab. And so when one correlates the post-PCI IFR with the QCA, while there is a statistically significant association, the R-square is 0.03, which basically means from a clinical standpoint, it's not a meaningful correlation at all, and it's really impossible based on the angiogram to understand if a lesion is in fact causing ischemia or not.